So just to introduce myself, my name is Clara Fong. I'm a final year medical student, and today I'm going to do this lecture, Pediatrics for Pals. It's going to take around 1 hour. So today I'm going to cover these topics. We'll start out with pediatric resuscitation, then we'll move on to taking a pediatric history, then the newborn and infant physical examination, and then I'll finish off by just going through a few bits about pediatric exams. I really appreciate that the things I'm going to talk about today, they're best learned hands-on, like history taking, examination, even resuscitation, like I don't have any videos. And I really recommend that you practice with stuffed toys, history taking with friends. I'm not sure about the situation with placements and finals, but I assume that if you do have finals in September, you might have OSCEs and things like pediatric BLS or pediatric history can come up. So that's why we can go through that. And I hope this PowerPoint serves as a guide, like for you to refer back when you're practicing these things by yourself. Also, just to mention or reassure you, this lecture is not really pathology heavy because I think there's like lectures coming later about pathology. So it's more like, guiding you on like the steps of resuscitation or like things you should ask in a pediatric history. So without further ado, we move on to pediatric BLS. So we start off with this question. It's a very simple question. You're babysitting for someone and their child, Bobby, 8 months old, is found unresponsive in his crib at home. So what do you do first? 1, you stimulate the baby. 2, you check for breathing and pulse. 3, you look for danger. And 4, you call 999. So the correct answer is look for danger. And with adult BLS, we all know, before we do anything, we need to check for danger because you don't want to get hurt. The second thing you need to do is you should stimulate the baby. So this is just trying to wake them up. You can say their name, you can rub their feet and arm, and while you're doing that, you're just observing the baby as well. Like, what do they look like? Because this will inform you like how well they are. If they look blue, if they feel floppy, then you know something's definitely not right. And if they're unresponsive, then you shout for help. So I took these steps from the Resuscitation Council guidelines, and they say that if there's more than one of you, one other person goes for help while the other stays with the baby. But if you're by yourself, you need to do at least 1 minute of CPR before you go get help. So you've called for help, and now you need to open up the airway. So as you might have noticed if you look at my slides, on the title it says BLS for infants up to 1 year old. There is a difference between like doing resuscitation for infants, so these are like babies up to 1 year old, and like children who are older than 1 year old. And I'll stick with infants first, and then I can talk about the different techniques for a child later. So in an infant, when you open the airway, instead of doing your usual head tilt and chin lift, you open the airway into a neutral position. So as you can see on the right, with this like these 3 different positions, the top one is the correct one, where the tip of the nose and the chin forms a straight horizontal line. The other 2 at the bottom are incorrect because there's one that is where the neck is hyperextended, and the other one where there's not enough head tilt. So making sure you're not tilting the head and neck all the way back, you then check for breathing and also look for any obstructions in the mouth. If you can see very obvious obstruction, very superficial in the mouth, you can try and remove it, but very carefully. don't put your finger into the mouth and just like move around, sweep around, as they call it, to find any obstruction, because you might push the thing further down into the airway. Apart from looking for any obvious obstructions, you need to check for breathing for up to 10 seconds. So like adult BLS, you do look, listen, and feel. So that's look for chest movement, listen for breath sounds, and feel for any breath on your cheek. And if you can't like sense that there's any breathing, or if there's agonal breathing, which is infrequent or regular breaths, you give 5 rescue breaths. So this is different from adult BLS, where you start with compressions. In infants and children, you give 5 rescue breaths first. So how do you do rescue breaths? So if you see the diagram on the right here, or the picture on the right, you need to use your mouth to cover both the baby's nose and mouth, and making sure you have a good seal. Once you're sure you have a good seal, you blow steadily into both nose and mouth for around 1 to 1.5 seconds. And while you're doing that, you need to make sure there's head tilt and chin lift, and that you can see the chest rise. Well, what if it's not rising, like it's not working? You, again, as I said, making sure that the neck is not overextended is one thing you should do. If it hasn't worked, you can try the jaw thrust method. But if you've done up to 5 times and each time it's not really helpful, just move on. There's no point in continuing trying to achieve for effective rescue breaths. So you've done 5 rescue breaths, or you've tried 5 rescue breaths. The next thing you do is you have 10 seconds, less than 10 seconds really, to check for signs of circulation and for the pulse. So signs of circulation are just things, is the baby recovering? Are they moving? Are they returning to the normal breathing? And check their pulse. So usually Resuscitation Council suggests checking the brachial pulse in infants. You can also try the femoral pulse if you can't feel for the brachial pulse. And you can try the carotid pulse if the child is older than 1 year old. If you're not sure, if you can't feel anything, no pulse, or there's a really slow pulse, less than 60, then you can start chest compressions. So in terms of compressions, there's 2 different ways to do it. And in my own experience, I was taught one way. I was taught the 2-finger method when I was on placement, and my other friends in other placement, they were taught another method, but both are valid. And according to Resuscitation Council, one is for when there are 2 or more rescuers. So I'll just teach both because they're both worth learning. So first of all, before you start compressing, you need to know where you're compressing. And you need to, first of all, find the civi-sternum. So on the baby, you find where the lowest ribs join in the middle. That's the civi-sternum. And then you put like 1 finger above that, and that's where you have to compress. So as you can see, the first technique is compress sternum with the tips of 2 fingers, and that's diagram B on the right. So you just use 2 fingers and compress the sternum, like the 1 finger above the civi-sternum. The second technique is the encircling technique, where you use both hands. And basically, your hands are wrapped around the baby's torso, and your thumbs are placed where you've just looked, the 1 finger's breadth above the civi-sternum. And then using your thumbs, you use your thumbs to compress that area, basically. I'm not sure why there's a difference, but I assume because if you're by yourself, you might need to call for help on a phone, and if you're using 2 hands, you can't really do that. So it might be more beneficial to be compressing the sternum with 1 hand than both if you're by yourself. The rate you should do it is at about 100 to 120 per minute, and you do 15 compressions, then give 2 breaths. So this is not adult BLS where it's 30 to 2. It's 15 to 2. So 15 compressions to 2 breaths. And you should the chest should depress by about 4 cm for infants and 5 cm for kids over 1 year old. So you keep doing these compressions until, like before, the ambulance arrives, you're tired, or the baby regains normal breathing, becomes conscious, or recovers. And now I've moved on to the slide for to talk about BLS for a child of older than 1 year old. And the difference is that for rescue breaths, you can do head tilt and chin lift, so you can make the neck a bit more extended than usual, and you can breathe into the mouth. So like adult BLS, you pinch the nose and you make a good seal around the mouth and breathe into it. For chest compression, you don't have to use fingers anymore, so you use the heel of one hand over the sternum. And if you're small, if you're a small person, or if the child is large, then you can use both hands with fingers interlocked, like adult BLS. So next we're going to talk about the choking child. So choking, or as they call it, foreign body airway obstruction. You would suspect it if there's sudden onset of respiratory distress, there's no other signs of illness, and there's a history of eating or playing with small items before the onset of symptoms. So if you have a choking child in front of you, first of all, you need to assess their cough. So whether the cough is effective or ineffective then determines what you do next. So an effective cough is if the child's able to cough loudly, they can take a breath before coughing, they're fully conscious, and they talk, like they can still talk to you, or they're crying. An effective cough is really the opposite. So it's a quiet cough, or they can't cough, they can't breathe, they're struggling to breathe, they're turning blue, and they're losing consciousness. If they're coughing effectively, then you just encourage them to keep coughing, and you monitor them and see whether they're able to cough out the obstruction or if they deteriorate into an ineffective cough. If their cough is ineffective from the get-go, then you shout for help, and then you determine the child's conscious level. So this is a diagram algorithm for choking. If it's an ineffective cough and they're unconscious, then you should begin with the CPR protocol. But if they're conscious, you can try back blows and thrusts. So again, this would be good to practice with a stuffed toy because you might not be able to practice it before OSCEs on a real model. So first, this is for infants. So again, a child up to 1 year old. You need to put the infant in a head downwards and prone position. Usually you support them on the length of your arm, and to make it easier for yourself, you can do this sitting down as well. So you need to, after you've put the infant on your outstretched arm, facing the floor, you need to support their head by placing like a thumb at the angle of the lower jaw, and then the other fingers at the same point on the other side of the jaw. So it sounds complicated, but if you look at the picture I've put on the side, that's what the person has done. You can see the fingers are sort of in a V shape supporting its jaw and head. With your other hand then, you aim for the area in between the shoulder blades and deliver up to 5 sharp back blows with the heel of one hand. It doesn't have to be fast. After those 5 back blows, you then turn the baby over to see if the obstruction has been relieved. Chest thrust is if the obstruction is still there and the child is still conscious. If they're unconscious, then you would have to move on to CPR. So for infants, again, chest thrust, you're turning the infant, holding the infant again, supporting them with the length of your arm. And again, the head should be facing downward. Not facing downwards. The head should be pointing downwards because gravity will help the obstruction relieve the obstruction. Again, after you've supported the infant down your arm, you need to support their head as well. And then remember I talked about finding the civi-sternum and then moving like a finger above it. Like it's the same landmark, and you're delivering like, it's like chest compressions as well with 2 fingers, but you do it at a much slower rate and it's much sharper. And after doing 5 of those, you check the mouth again to see if the obstruction has been relieved. And you keep doing this until the obstruction comes out, or until they turn, if they become unconscious, then you move on to doing CPR. For a child more than a year old, as you can see on the picture, the first picture, you can place them across your lap, like with you sitting down. But if this is not possible, for example, the child is a bit bigger, you can make them lean forward, and then you can deliver the blows from behind. And for children who are more than 1 year old, you can do abdominal thrust, which you can't do for infants. So to do abdominal thrust, you stand behind the child and basically wrap your arms around their torso. And you make a fist with one hand and put it in between the umbilicus and the civi-sternum. With your other hand, you hold onto your fist and then pull inwards and upwards. Inwards and upwards. And you do this for up to 5 times. And make sure you don't lift the child off his feet. If you do that, that means that, you're putting too much force, and this can cause trauma. Okay, so I've gone through pediatric BLS and also how to manage a choking child. I haven't added any videos in here, but I would strongly recommend you watch some videos online on how to do it, and so you get a better idea. It's always better to watch a video than to just hear someone talking about it, and also practicing it on a model or a stuffed toy, as I like to say. So moving on, I'll be talking about pediatric history taking. So I'm sure everyone knows how to take a history and what they'd say to, before they start taking a history. But I guess just a few tips with regards to pediatric history. You need to know who is in the room with the child. I have made a mistake of calling someone, oh, this is, granddad, when it was actually the kid's father. So that was really embarrassing. To avoid that kind of mistake, you should always check like, oh, and you are, or how are you related to the child? They will tell you it's okay to ask. Don't assume that every adult who comes in with the kid is their parent. Like it could be their aunt, their uncle, their grandparents. Sometimes even like if they don't live with their parents, and could be someone else. You can address questions to the child if you think they're old enough and they're able to answer you. First of all, it's good for history taking because they're the ones experiencing the symptoms. They know best what they're going through. But also, if they're old enough to answer you, it's basic sign of respect. Like they're here to see you, and you shouldn't just talk to their parents. You should talk to them too. And keep in mind that if you want to ask questions about certain sensitive topics such as sexual history, smoking, drugs, you can ask to speak to it could be teenager or adolescent alone and without their parents there. So we all know how to take history, and I'm just going to elaborate on the bold points I have here on the slide. So bits about general review, birth history, vaccination record, family history, and social history. I think like in these, I guess like in there I've put sort of questions more orientated to children. So I'm not sure if you've seen or heard of this traffic light system. GPs like to use it. It's basically a assessment criteria for children under 5 years old who present with fever. And it's basically like you look at these criteria and ask through history and examination, see if they have any that fall into amber or red categories. Because if they do, this means that the child is of a high risk of having a serious illness, and this determines sort of the management afterwards. If a child comes in and is in the green category and they're low risk, they can be managed at home. If they're amber, then you would think that they have to see maybe a specialist. And for red, they have to see a specialist or healthcare professional really in 2 hours time. So if you were at the GP, you would definitely send them to the hospital immediately. And so looking at this traffic light system, this informs us of what kind of question we need to ask in the general review. So the general review questions I have here are things like in terms of the feeding and drinking. So in terms of feeding, you can get an idea of the nutritional status and also their hydration status as well, because sometimes milk comes under feeding. You can ask the parents like, what are they eating? If they're an infant, you can ask if they're fully breastfed, if they're bottle fed, or if it's mixed. And then usually sick kids, they eat less. So you want to quantify how much they're currently eating. Maybe, they're eating like half of what they used to, or they're barely eating anything. And this gives you an idea of how ill the child is. Around similar vein would be drinking, like how much are they drinking? Are they drinking any water? And the next question that I have is, are they producing wet nappies? And again, this informs us of their hydration status, because if they're dehydrated, they won't produce as much wet nappies. So again, you have to check, are they still producing the same amount of wet nappies each day, or is it less? It's something you need to check as well. And then you can ask, how are they doing at home? Are they like really active or lively, or, are they playing around as usual? Because sick kids, they'll become cranky. They can become, if they're more ill, they become drowsy, like not responding well to social cues. So again, this gives you an idea of how ill the child is. If a child comes in with a fever, they're not eating as much, but they're still, playing around with their siblings, they're playing with their toys, still, smiling, not very cranky, then you're less worried that it's going to develop into a more serious illness. And one thing you can ask, and this does not apply to just a child with fever, really, all these questions, but it's always good practice to ask for the Red Book, which is the personal child health record. And parents should be encouraged to bring it along with them whenever they see a doctor. And in there, you can check their growth and check their immunizations. So another question I would always ask, and I've put it in here, is like, do they have any concerns with their development? Later on, I have a slide that goes through sort of a few things you should ask for developmental history, but I know that there's another lecture that's going to go through developmental milestones, so I'll leave it. I won't go too deeply into that. Usually when I ask about development, which I do ask in history for a young child, I don't go in depth and ask them like, when did they start walking? When did they start talking? Like, can they draw this? Like, if someone's coming with a fever, I'm sure development would not be the main concern. But as a good habit, you can check by asking first if there's any concerns, and then asking them specifically any concerns about walking, talking, like, interacting with like the parents and people around them. And if the parents have concerns, usually they will bring it up. So the next thing I would talk about is birth history. Again, birth history is a thing where you might not have to ask like for every pediatric patient that comes in. Like if a teenager comes in with something like a headache, like you have to think, if birth history really relevant in that particular history. But I'm sure the uni wants us to do a more thorough history taking, so it's good to practice asking these questions as well. But in reality, you might find that like there's not much point in asking that, but if you have the opportunity, you can practice it. So things you need to check is were there any problems during the pregnancy? What was the type of delivery? So was it vaginal or was it a cesarean C-section? Were there any problems during the delivery itself? And then if you're worried about sort of a neonate and you're worried about infection, then you have to especially check for things like prolonged rupture of membranes, group B strep, and maternal fever during delivery. And then other things you can ask is how much did they weigh when they were born and what gestation week were they born in, just to check if they're premature or not. And then you need to check with the parents if there were, problems after the birth and did they have to stay in the hospital for a while, because, they can develop problems such as jaundice, or like the doctors in the hospital might have found something on the NIPE and like they had to be admitted for investigations. So these are things that are worth asking in birth history. So vaccination record, it's very simple. Just ask them if they've had all their vaccinations. I haven't had anyone lie to me about vaccinations yet. They're usually truthful about what they haven't had yet. And if you're in doubt, always you can check the Red Book. In terms of family history, you can ask like, have any members of the family had similar problems or any other serious disorders? And check for consanguinity. These are more applicable if you're thinking it's a genetic problem. And it's very rare that to have to ask for the consanguinity question. I personally myself have not tried it before. It's something that could come up if you're going to work in pediatrics in the future. So, yeah. And lastly, social history. So you start off with asking for who lives at home with the child. So you find out a bit more about the family structure and who's looking after the child. Pets, you should ask about pets if you think, the history is related to allergies or asthma. You can ask about the housing situation. You should ask if anyone smokes or drinks in the house. And then with the child, you should ask them, about school. Like, how are they doing at school? Are they happy? It's a good way to build rapport and find out, if they have any problems. I mean, especially mental health problems that are more prevalent nowadays. It's good to ask about school. And lastly, you can ask about if there's are there any social workers involved? Because this can be a safeguarding concern, or at least you start thinking about safeguarding. So here I've put a slide on developmental history. It in itself is a pediatric history sort of scenario that you can practice. But because I'm not going through milestones today, I'm going to briefly talk about, how you would go about with a developmental history. So likely the parent would come in worried about certain aspects of their development, their vision, their hearing. It could be their walking, their talking, or interaction. And based on that, as usual, you take your history, do your presenting complaint, history of presenting complaint, and then check the associated symptoms based on what they've come in with. And then you need to double check you need to check with them the key developmental milestones. So if they've come in with a talking problem, if they're not speaking, even at 1 year old, you still need to check whether they have any problems with walking, with their gross motor, with their fine motor, with their social areas. Things you can also ask would be child's behavior and like temper, because this can relate to conditions such as ADHD, autism. And then other things you can ask are bladder and bowel control and sleeping problems. And then just to sort of round it off, you can ask if they've had previous developmental checks and whether their nursery or school has expressed any concerns about their child. So next thing I'm going to talk about is newborn and infant physical examination. This is usually done within 72 hours of the infant being born, and is also done around 6 weeks at the GP. So you can either practice it in GP or in the hospital. So as with every examination, you do the whole wash hands, introduce, explain, and then you need to gain consent, and then the infant should be undressed down to their nappies. And this NIPE is an opportunistic exam. Later on, I'll be talking through each of the steps, like head to toe, but if the infant is quiet, you should listen to their heart first, or if their eyes are open, then you check for the red reflexes. Before you start with the exam, you actually have a lot of questions to ask, and these questions, if you do a pediatric placement, you might see a doctor asking them, and it's good to just see how they go through these questions and learn why they need to be asked. So the questions are a bit similar to the type that you ask for birth history, such as type of delivery, were there any antenatal screening results, any abnormalities on scans, were there any maternal fever, premature rupture of membranes. You have to check if the baby came out head first or feet first, because if it's breech presentation, the baby will need an ultrasound scan of the hips to look for developmental dysplasia of the hip. And then you need to ask if they're first-degree relatives with hearing problems, hip dislocation, childhood heart problems, congenital cataracts, and renal problems. And these are the things you're sort of looking for during your NIPE. And then after you've asked all of that, you just need to check the baby itself. So you just ask questions such as, have they had their first poo? How are they feeding? Are they drinking milk? Are they peeing? And is there anything that the parents are worried about? So to start off with, just by inspection, you want to look at the color of the infant. You can tell if the infant is jaundiced, if they're pale or blue. If an infant is cyanosed, you start thinking whether they have a congenital heart problem. And looking at their posture, you're trying to see if there's any abnormalities. So here on the right, I actually have this picture of an infant with Erb's palsy. Erb's palsy, if you've forgotten, it's damage to the upper brachial plexus, C5 to 6, and it would be most likely due to birth trauma. And the tone-wise, you can kind of see already when the infant is being picked up and placed on the examination table, what their tone is like. And if it's a hypotonic infant, they're usually like described as a floppy baby. So as I said, we're starting from the head. So first thing you do is measure the head circumference. Then next thing you do is you need to check the shape and look at the cranial sutures. And in particular, you want to feel for the anterior fontanelle as well. So I am on the right, I have two pictures, and you can see on the second picture the position of the anterior fontanelle, where it should be. In fact, that one is a sunken fontanelle, which indicates dehydration. The anterior fontanelle should be open because it actually closes at 18 months. And if it's really tense, if it's bulging, then it suggests a raised intracranial pressure. So you'd be worried about hydrocephalus. If the fontanelle itself is very wide, more than 4 fingers width, you'll start thinking about things like, if there's congenital hypothyroidism, if there's Down syndrome. So here, I have a few head conditions that you might see on an infant's, head. So cranial molding is just like the head of the baby is not in its usual round shape. It's in a weird shape. But that's usually common after birth and can resolve. The caput succedaneum, which is the first one, as we can see on the left, it's where there's subcutaneous fluid collection directly underneath the scalp, which can cross the suture line. There's cephalohematoma, which is bleeding right with underneath the periosteum, so that's periosteal hemorrhage, and this does not cross the suture line, and this can cause jaundice. Subgaleal hemorrhage is actually quite a rare condition, but it can cause life-threatening blood loss, and when there's bleeding between the galeal aponeurosis and the periosteum, and this is due to rupture of the veins between dural sinuses and the scalp veins. Cranial synostosis is when there's premature fusion of the fibrous sutures, and this can lead to raised ICP and damage to the intracranial structures. So the next thing after you've looked at the head is to look at the face. We're moving downwards now. So you have to check if the infant has dysmorphic features. Just because there is a negative screening result or nothing showing up on scan does not mean the baby cannot have dysmorphic features when they come out. It is uncommon, but parents have found out that their child has Down syndrome after they've given birth. So screening results might not detect it, but it's still something you should look out for. So on the right here, I have 2 pictures and 2 different syndrome and their corresponding dysmorphic features. So the first one is fetal alcohol syndrome, and the second one is Down syndrome. So things you can definitely read the words on these pictures. So I'll just talk really quickly what you should look out for. So flat occiput means that the back of the head is flat. You should look at the nasal bridge, see if it's flat, low as well. Palpebral fissures is basically the length of the eye from the medial corner to the lateral corner. So in fetal alcohol syndrome, this is small, and in Down syndrome, this is upward slanting. Brush field spots are basically these white flecks in the eye that you can see in a child with Down syndrome. And micronathia, as you can see in the diagram for fetal alcohol syndrome, just means a small receding chin. Yeah. So after you've looked at the face and You're happy that there's no dysmorphic features. You inspect the rest of the face, looking for any trauma. You're looking just quickly at the nose, seeing if the nasal passages are patent. Then you look at the ears, because check the position, because low set ears is a feature in Down syndrome. You should look for any skin tags or pits as well. So moving on to the eyes. As I said again, if the eyes are open, check the eyes first. When the baby starts crying, when they cry so hard, their eyes close up and you can't see anything, and it's a bit of a hassle to try and open their eyes then. But before you check for red reflex and look for retinoblastomas or cataracts, you need to check if there's evidence of conjunctivitis. So in neonatal conjunctivitis, it's usually caused by a bacterial infection from chlamydia or gonorrhea, and if untreated, it could cause blindness, so you do need to rule that out. You can check if there's any evidence of jaundice in the sclera, and again, this is part of looking for dysmorphic features, but you're looking at things like epicanthic folds and also hypertelorism, which is basically a widened distance between the two eyes. So after you've done all that, you can then assess for the red reflex. You use the ophthalmoscope, and if there's an absent red reflex, you need to refer directly to ophthalmology quickly, because it could be, again, cataracts or retinoblastoma. After the eyes, you can look at the mouth. So this part is where the child is likely to cry, because you have to use a tongue depressor and a torch to see the whole palate and see the uvula. Usually you'd start off with putting a gloved finger into the mouth to feel for it, but that's not enough. You do need to visualize it. You should also look at the tongue and to see if there's any evidence of tongue tie, which I've put on the right. That's what tongue tie is. This can affect the infant's feeding, and it can be corrected, so it's something that you should look out for. While you're at the mouth, you can test for two reflexes, so that's the sucking reflex and the rooting reflex. With the sucking reflex, you just need to put your finger into the mouth, and the infant should immediately start sucking on it. As a tip, it is actually a good way to try and stop an infant from crying. Like when you want to calm them down, you can put your finger into the mouth. Another one you could do is rooting reflex. So basically, you just stroke one side of their cheek or the corner of their mouth, and the infant should turn their head towards you. So quickly moving on to the neck, you just have to look at the neck and feel the clavicles. You're trying to rule out any neck swellings like cystic hygroma, which we have here in the corner. That's a cystic hygroma. And also you need to rule out clavicular fracture that happened during birth. Then you're moving on to the arms. Like, apart from making sure that they're same in size and length, you need to check if there's the right number of fingers, that there's no polydactyl. You need to look at the palms for palmar creases, because single palmar crease in both hands is a feature in Down syndrome. You can then palpate for the brachial pulse, and you can also do the palmar grasp reflex. So what that does is, if you just put your finger into the child's hand, they will close and form a grasp and hold onto your finger. Next thing we move on to is the chest. So after inspecting and finding if there's any deformities, you can listen to the heart and lungs. Obviously, you should do this when the child is quiet and not crying. This will make your life so much more easy. In terms of the lungs, so the respiratory exam, you need to rule out any respiratory distress. So here I've put the features of respiratory distress, which I'll go through later as well. And then afterwards, you need to listen to the lungs and listen for any added sounds. For the heart, and you need to check the heart rate, and you also need to listen for any added sounds. After you've listened to the lungs and the heart, then you move on to the abdomen. You need to look for any evidence of hernias or any obvious abdominal distension. And then afterwards, you can feel the abdomen. In an infant, you might be able to feel for the liver, spleen, kidneys if you're feeling hard, like pressing down hard enough. And the liver can be around 1 to 2 centimeters below the costal margin, but should not be more than that. And after you're satisfied with your abdomen palpation, you have to inspect the umbilicus to look for any hernias or discharge. You're wanting to rule out infection of the umbilicus stump. So if it's red and smells bad, then you have to think about infection. Moving from the abdomen, we go down to the lower limb. And now you can remove the nappy. And this is a tip from doctors I followed. They remove the nappy, but they don't remove it completely. They loosen it so you can access the lower limbs easily, but they still keep the flap covering the genitals because you do not want the baby to pee on you. So this is something you should think about. So again, like upper limb, you can inspect the limb symmetry, and ideally, hopefully, you would have seen the tone and movement of both lower limbs. Then you should palpate the femoral pulse. Again, this is something that is best done when the child is quiet, because if they're crying, again, it can make it hard to feel. In aortic coarctation, femoral pulses can be weak, absent, or delayed, so you do have to check it both sides. Then you look at the foot, looking for any ankle deformities, such as clubfoot, and also make sure there are 5 toes on each foot. So after you've done those, you can do the Barlow and Ortolani test to look for hip dysplasia. So how I remember it is Barlow, B is bad. You're basically trying to dislocate the child's hip. What you do is making sure that the child's hip and knees are flexed at 90 degrees, as you can see on the diagram on the right. You put the legs together and then you push down on the knee with your thumb, and you're pushing down, like directing the force towards the back. While you're doing that, your other 2 fingers should be wrapped around your thigh, so it should be at the back. And if there's a positive, if the hip does dislocate, then the fingers at the back will feel the sensation of subluxation or dislocation. So you just have to put the legs together and then push down, hoping that your other 2 fingers at the back can feel that sensation. Ortolani's test is basically replacing a dislocated hip joint. So you have to do both. You have to do Barlow and Ortolani. You can't just do one and not the other. What you do, again, make sure the hip and knees are flexed to 90 degrees. Then what you do is you need to, using your thumbs, you're abducting the legs. And again, your 2 fingers are at the back as well. So if there's a relocation of the femoral head, you can feel the clunk as well as hear the clunk. Just a reminder that doing the Barlow and Ortolani test will make the child cry. So it's good to do all of those sort of sensitive examinations before you move on to that. After we've done both tests, we can look at the genitalia. So you have to make sure that there's no ambiguity of genitalia, because this can be a sign of disorder of sexual development or congenital adrenal hyperplasia. So in CAH, Boys will have normal genitalia, but girls can have enlarged clitoris, or the genitalia might look more like a male's one. If the baby is a boy, you have to look at the position of the meatus to exclude hypospadias. You also have to feel the scrotum to ensure that the testes are present. Sometimes they can take a while to descend, but if both are absent, then you need to investigate for a disorder of sexual development. For females, you should inspect the labia to make sure it's not fused, and you should check on the clitoris to make sure it's not enlarged. You might see some white discharge, and that's normal, and it's due to maternal estrogens. After you looked at the genitalia, it would be best to put the nappy back on. And then afterwards, you can turn the baby and rest them sort of on your forearm, so you're looking at their back. So primarily, what you're looking for at the back are signs of spina bifida. So in particular, we're looking for things like sacral pit, which we have here on the first picture, and for hair tufts and things like that. And you should always be on the lookout for skin abnormalities like nevus or just birthmarks, because you do have to record them down. After you've done with looking at the back, you can move to do the two final reflexes. So the first one is stepping reflex. What you do is you hold the baby upright so their feet touch the examination table. If it's normal, they will put one foot in front of the other, like they're walking. The next one you need to do is moral reflex. And before you do it, you need to tell the parents that you're going to do this test and that you're going to drop their baby, but in a very safe manner, safe and controlled manner, so they don't get surprised when you do it in front of them. What you need to do is support the infant's upper back with one hand, and your other hand is basically in a much lower position. Once you're satisfied that everything's safe, you can drop the hand that's supporting baby down towards your other hand. So with this falling sensation, the baby should extend their legs and head, and their arms should jerk up, and then they would bring their arms back together, and then they'll start crying. So as I mentioned just now, throughout the entire examination, you should be looking at their skin for things like birthmarks, hemangiomas, Mongolian blue spots. So the one in the middle is the Mongolian blue spot, and the one on the right is the nevi, strawberry nevi. And again, you need to see if the baby is jaundiced or not. And the one on the left is a jaundiced baby. I appreciate it's not very easy to tell that it's jaundiced, but you might be able to notice that the skin has a slight yellow tinge to it. So towards the end, I'm going to just talk a bit about pediatric examination, in particular cardiac, respiratory, abdo, ears, throat, and skin. As I've mentioned, I won't go through each individual step of what you need to do because the steps are basically the same. But I will mention, what I'll be talking about are bits that doctors like to ask, and important things you should look out for. So as with any pediatric examination, explain what you're about to do to parents and child. And I've read and I've been told that for certain kids at a certain age, like quite young kids, if you ask them, oh, is it all right if I listen to your chest? They can say no, and then you're stuck because you still have to do this examination. So it's for younger children who might be a bit more unpredictable. You're allowed to say, I'm going to listen to your chest now, because, and of course with a parent next to them, because examination is an essential part of the consultation. Obviously, if it's an older child, teenager, or even a 10-year-old, 11-year-old, based on your own judgment, like, what you think, like, are they going to cooperate with you? Of course, you should ask for consent. Is it okay if I listen to your chest? Because you would then not be worried about them being naughty and saying no. As usual, you should leave unpleasant procedures until last, and these would include looking into the ears and looking into the throat. And if you're examining teenage girls, you definitely need a chaperone, or like make sure that the mother stays in, or you find a nurse. Usually, this is not a big problem as most kids are seen with their parents, but for teenage girls, this is something you need to keep in mind. So by just inspecting the child, you can find out a lot, like whether they're going to cooperate with you, just by the level of consciousness, are they distressed or not, like, do they look blue? You can find out a lot about how well or how unwell they are. Don't tower over the child when examining them, like that's intimidating. Try and develop rapport with the child, like hopefully you've done some during the history taking bit, but if not, like you can use distraction. You can ask the parents for help, or you can have something by your side to help distract the kid. And you have to be honest about when things will hurt. Like you should tell them so they can prepare themselves. So obviously you need to check for vital signs. If you remember the traffic light system, some of the criteria relate to things like respiratory rate, heart rate, and also you need to check if they have a fever or not. So you have to check those, and oxygen sats, blood pressures. Remember to have the right kind of cuff, a pediatric cuff. And also, while a child is at the GP, you can also check on their growth and plot on the appropriate curve, making sure you're doing it at the right age and the right gender. It would be good practice to do a few of these plotting when you're at the GP. So moving on to cardiac exam. One of the things you need to learn is the features of heart failure in infants, and it's what you look for when you examine an infant. So these features would be, as I've written here, poor feeding and failure to thrive, if they're sweating, if there's tachypnea, tachycardia, if there's cardiomegaly and hepatomegaly. And here on the right here, I have a picture that shows sort of the appropriate ranges of heart rate for each individual year. I think it's worth learning, and I appreciate it's quite difficult to learn, like remember for each individual one. But it's like in I don't remember if they provide those values in exams or not. I think they do, but on the off chance they don't, you're better off remembering it. On auscultation, sometimes you can hear a splitting of the second heart sound, and that's normal. That's a physiological splitting. It's much obvious when the child is breathing in. However, if you hear the splitting of a second heart sound and it doesn't change with breathing in or out, that's called fixed splitting, and this is heard in atrial septal defects. So in terms of murmurs, I won't go through all the individual murmurs because that's a lot. That's like I'll be teaching congenital heart disease. Instead, I'll teach you how to differentiate between an innocent and a not innocent murmur. So innocent murmurs are murmurs which you don't have to be worried about, and there's something we call 7S. So it's to help you remember the characteristics of an innocent murmur. So it should be a short, a single murmur. It should be small, so a localized murmur. It should be soft. It should be systolic. It should be sweet, so not harsh sounding. and also sensitive, so it changes with the child's position or with their breathing. If they have these features, it's most likely a benign murmur. So significant murmurs would be the opposite of what I've just said. If it's very loud, or if it's all over the precordium, if you can feel it on the chest, so with a thrill, if it's a diastolic murmur, if you have any abnormal cardiac signs, such as the ones I mentioned before with heart failure, then it is a significant murmur that is worth investigating. So if I mentioned hepatomegaly is a sign of heart failure, and just to refresh your memory, normal is 1 to 2 cm below the costal margin. Like abnormal is more than that. Again, I mentioned before, you need to check femoral pulses because in aortic coarctation, there's a decreased volume or you can't feel it. Moving on to respiratory exam, things you can look out for are, for example, clubbing on the hands. They can show up in things like cystic fibrosis or cyanotic congenital heart disease, occasionally seen in IBD as well. Other peripheral signs would be things like cyanosis. It's very important to check the respiratory rate. And I have here on the right, again, a table showing the appropriate respiratory rate ranges for the different age. Again, it's worth learning it. You also have to learn about the signs of increased work of breathing. It's something doctors like to ask as well. So certain signs that show that a baby is finding it difficult to breathe would be if you see that they have nasal flaring, if you hear grunting, if you see them use accessory muscles, and if they have difficulty feeding or speaking. So here I have a list of respiratory sounds. So I have the sound followed by the condition. There's, for example, if you have a cough with wheeze, it could be things like asthma or viral-induced wheeze. If it's productive, it could be lower respiratory tract infection. Then you have to remember barking cough. Barking cough is related to croup. Dry cough can be related to allergies, but also you can't rule out TB. Then there's stridor. Stridor is really a harsh, low-pitched inspiratory sound, and it's caused because of upper airway obstruction. It's really worth going on to YouTube and listening to stridor and barking cough and whooping cough as well. These are all things you should listen to. Once you hear it, you won't forget it. And you can hear stridor in croup if you have foreign body obstruction, if you have epiglottitis, but that's really rare. Laryngomalacia is when the larynx is very floppy, and this can cause stridor as well. Bronchiolitis is quite a common condition in very young children, and you can hear fine crackles in all zones if they have bronchiolitis. And then whooping cough, pertussis, like as the name suggests, is a really severe cough, which is followed by this really high-pitched inspiration, which sounds like a whoop. I mean, I can't do it, so that's why I tell you, you should go onto YouTube to have a listen to these kind of sounds. So next is abdo exam. In abdo exam, you'd be looking for organomegaly and masses. So here I have a list of causes of hepatomegaly. They're not entirely different from adult causes of hepatomegaly, except if you look at malignancy, kids are more likely to have leukemia, neuroblastoma, Wilms tumor. And in terms of metabolic causes, glycogen and lipid storage disorders, they would be found quite early on, yeah. There's also causes of splenomegaly, and again, they're not entirely different from adult causes of splenomegaly as well. One thing to note is systemic juvenile idiopathic arthritis is also a cause of splenomegaly. So in terms of abdominal exam, you're looking for masses. It's most likely if you do feel a mass, like the most common mass you would feel would be fecal masses due to constipation. These are usually mobile, non-tender, and found around the suprapubic area. Other masses that are not common, but you shouldn't really miss, would be Wilms tumor. So Wilms tumor is a renal mass, and it's a firm, smooth lump. If it's really big, you can sometimes see it protruding from the side of the abdomen. It doesn't cross the midline, which is different from neuroblastoma, which is an irregular firm mass that can cross the midline. But usually the child is very unwell with that. Lastly, I've put pyloric stenosis. You might see that a lot in past night questions, but something about an olive-shaped mass in the right upper quadrant. Yeah, that's pyloric stenosis. Then moving on to the ears and throat. As I said, these are very sensitive tests. Kids don't like it, so leave these till the end. One very important thing before you examine is to tell the parent how you want the child to be held. So it's quite similar for both ears and throat. For ears, you ask the parent to hold the child so they're sitting on their lap, but they're facing the side. So the parent wraps their arm around the child, and then the other hand holds the head against the chest. This is to stop them from moving around. So in infants, because the auditory canal curves upwards, you have to pull the ears down and back. If they're older than 3 years old, this is when the canal curves downwards and forwards like normal people. You can pull up and back. And in the ears, you're looking for any swelling, any redness, any perforation, dullness, any fluid. So you can see the first picture I have is quite red, it's bulging. This is otitis media. And the one on the right, the second one, you can see that a grommet has been inserted. So you also will have to check the throat. So again, this is an invasive examination, and kids really don't like it when you use a spatula to look at the back, but it's required really for children usually under 5 years old. Like examining the ears, the child sits on the parent's lap, but this time facing forward. And again, the parent puts one arm around their body and one hand holding the forehead, like on the forehead to hold the head in place. You should ideally do this examination quickly to not prolong the kid's suffering, but sometimes you'll just have to push the spatula in, because otherwise you won't be able to see anything. What you're looking for is really looking at the tonsils, the pharynx, the uvula, and usually you're looking for signs of tonsillitis or pharyngitis. So you need to check for any redness, if there's swelling, if there's pus, if there's petechiae. And here I put some causes of petechiae. The first picture there is what it would look like. And a common cause would be Streptococcus pharyngitis. You can use this opportunity to look for any dental caries or any teeth abnormalities. Lastly, when you do an examination of a child, I would always first check with the parent if there's any rash during history taking, but especially if they do have any fever, when I'm examining, I would try and look for rashes on the body as well. If obviously if they come in with a rash problem, you definitely have to look at it. Remember to look out for sepsis. That's very important. That is very important. And you do that by not just history, not just examination, but you need to check if there's any rash. Non-blanching rash. Here I actually have a picture. It's not a sepsis rash. It's actually Henoch-Schönlein purpura, HSP. It's non-blanching, but it's a palpable purpura. It's slightly different. And the distribution is usually in the lower legs, at the back of the legs, and in the buttocks as well. Usually the child will have other symptoms, such as abdominal pain. And here I put lymph node enlargement. It's not uncommon for parents to come in to say that their kids' lymph nodes have grown. So you can do your normal lymph node exam, but you, as usual, comment on where you felt the lymph node, like its mobility and what its consistency is like. And then you also have to check if there's any scars or injuries, just because, these could be signs of abuse, and you need to raise safeguarding concerns if you're worried about abuse. So I think, yes, this is the end of my presentation. It was a bit longer than an hour, but I hope it's given you a basic outline of how you should do pediatric resuscitation, and also what kind of extra questions you need to ask if there's a kid sitting in front of you, and sort of what you should be looking out for when you're doing exams with a child.